Hi, I'm Dr. Ginevra. Welcome to day 26 and 30 days of my Fibro life. I'm going to talk very briefly about a really hot button issue, and that is opioids for chronic pain and fibromyalgia management. And I've been thinking about this a lot because I'm on call this weekend and I work now part-time in an addiction treatment center. And I have definitely seen the other side of opioids, and opioids certainly, when they grab on to somebody's brain and start that kind of addiction process, they can be life destroying and life ending. And I think what happened, like in 2016, when the CDC came out with their guidelines around that really kind of recommended significantly lower amounts of opioids and, really recommended kind of prescribing opioids much less frequently. It was done in response to the fact that there really had been a significantly increasing trend of both opioid overdoses and opioid addictions. And in part, the overdose death rates really went up because there was more potent opioids available on the street, and namely that's fentanyl. But, a lot of people that end up, unfortunately, with an opioid use disorder, their first exposure to that opioid was in the form of a prescription given by a well-meaning dentist or doctor, maybe after a surgery or an injury. And so I think what the CDC guidelines in 2016 were trying to say is, hey, from a public health perspective, we recognize that if we expose less brains to opioids, there's less risk that that opioid is going to kind of put its hooks in the brain and develop the disease of addiction, which unfortunately is a very deadly disease. So well-meaning, good intentions, but those guidelines were really interpreted as almost like law. And seemed like all of a sudden, so many patients that were dealing with chronic pain and had been reasonably well managed on opioids for, even sometimes many years, suddenly had their medications, really rapidly tapered or just stopped. And it was really, those guidelines were really interpreted so broadly in a very black and white manner that it's like the pendulum totally swung the other way. And then it was like opioids for no one. And I think particularly in the field of chronic pain and fibromyalgia pain management, we have to really recognize, and this is what I've always said, and I've talked about it in the Fibro Manual and in several blog posts that I'll link to in the description below, is I don't think that we should throw the baby out with the bathwater, which is such a weird expression, but with opioids. I think what we need to do is, in response to the CDC guidelines and the recognition that certainly opioid exposure, prescription opioid exposure, is a potential risk factor for development of opioid addiction. I think what really needs to happen is becoming more thoughtful in how we prescribe opioids. And that doesn't mean opioids for no one or opioids for everybody. What it really means is opioids, in my opinion, should be viewed as sort of a last option, after all other tools have been tried. Or, frankly, if somebody doesn't have access to other tools, whether due to, health insurance restrictions, financial restrictions, maybe they don't have access to something like the myofascial release therapy that I recommend because I've seen how helpful it can be for reducing fibromyalgia pain. If somebody doesn't have access to that, and let's say they've tried other prescription options available for fibromyalgia and they just don't work, or they have side effects from them, I do think that opioids should still be considered in the chronic pain toolbox. But I think the safest way to prescribe them is actually not for daily dosing. I think they actually are much safer if they're prescribed sporadically for kind of as needed flares. So rather than taking an opioid every day to manage fibromyalgia pain, which is kind of how we used to prescribe opioids for chronic pain, I've seen that if we say, okay, let's say out of 30 days in the month, on your 10 most painful days, you can take, one Vicodin or something. That kind of opioids for flares does a couple of really, really important things. Number one, unlike when you're taking daily opioids, you don't develop a physical dependence on a medication that you're taking sporadically. So physical dependence, not the same as addiction, but what it means is over time, your body gets used to it. Gets used to that. Let's say you start with 2 Vicodin a day. Over time, your body gets used to that 2 Vicodin a day. And it will say, okay, if you stop that suddenly, I'm going to give you symptoms of withdrawal. And so that's where dependence comes in. And then along with dependence comes this other very unfortunate phenomenon of tolerance. And that means, maybe after a year of being on the 2 Vicodin a day, it's just not working like it used to. You're just not getting the pain relief you used to. Now you have to go up to 3 a day, and then 4 a day, and 5 a day. So the combination of dependence and tolerance are both very negative outcomes from daily opioid use that can be avoided with more intermittent, only as needed for flare use of opioids. The other thing is, if your brain is not kind of bathing daily in opioids, it is less likely that you will develop the abnormal behaviors around opioids that we call addiction. And so some people confuse dependence and addiction. Addiction is really behavioral, and it's also, it's a result of kind of biochemical, physiologic changes in your brain. And the way I think about it is, it's like there's a substance there, and you can be doing fine with it for a long time, and then for whatever reason, it suddenly is kind of hooked into your brain. And now the actual substance becomes a problem. And this is where, overusing, not being able to stick to medications as prescribed, maybe needing early refills, maybe trying to control your use but not being able to, hiding your use, and really kind of using the medication inappropriately. You're no longer really using it for what it was prescribed for, what it was intended for, which is pain management. Sometimes people are using it for kind of mood modulation or other things like that. So I feel like the way that we can best kind of find the balance between safe opioid prescribing and lessening the public health crisis that is opioid addiction and rising opioid overdose deaths is to try to find smarter ways to prescribe opioids. Yes, let's try to limit them to only the most appropriate cases. And hey, insurers, if you're so worried about these issues, maybe you should consider covering things like myofascial release therapy or other non-opioid approaches to managing chronic pain. So with that, I will get off my soapbox, and I will say thank you for joining me. Till we meet again, stay fierce.